Good evening, ladies and gentlemen. I am Dr. Kimberly Jeffries Leonard, Vice President of Administration for the Black Women's Agenda, Inc. Welcome, welcome to the Black Women's Agenda's I Am the Change, Vaccines for Your Best Health Town Hall in partnership with the Risk Less, Do More campaign. The Black Women's Agenda, or BWA as we call ourselves, was founded in 1977 to highlight and address those issues that uniquely impact the lives of Black women and their families. We are currently celebrating our 47th year, and we continue to work tirelessly to serve millions of women in areas of health, education, and economic empowerment. Working with and through our 24 national collaborating organizations, BWA's programs have national recognition and global impact. Tonight, we are pleased to host this town hall in collaboration with our national collaborating organizations, the National Medical Association, and the Black Coalition for Health. As we get started, and to begin tonight's program, I have the honor of introducing our first panelist, May Malik. May is the Deputy Assistant Secretary for Public Affairs for Public Education with the United States Department of Health and Human Services. She has over 14 years of cross-sector experience developing external affairs strategy. As HHS's lead advisor for public education initiatives, May oversaw the work of the We Can Do This campaign, which in its first year administered nearly 60 million doses of the COVID-19 vaccine, which prevented nearly 250,000 hospital visits and saved over 50,000 lives. Won't you please join me in welcoming May Malik to our virtual stage? May.
Thank you so much. I hope everyone can hear me okay. Thank you for that lovely introduction. My name is May Malik. I'm the Senior Advisor and Acting Deputy Assistant Secretary for Public Education at the U.S. Department of Health and Human Services. I have the honor of leading large-scale communications and outreach campaigns that connect the American public with the information that they need to stay healthy, to really complement the work that is being done by the doctors all over the country, like the ones that are on the call today. One campaign I'm here to talk to you about is Risk Less, Do More, which is a national effort that helps people protect themselves and their loved ones against viruses that we've come to expect this time of year, the flu, RSV, and COVID. The Risk Less, Do More campaign launched in August. It uses tested messaging to encourage COVID, flu, and RSV vaccinations through ads on television, on social media, radio, in magazines, and in ads that you've seen on bus shelters or on billboards. And to really drive all this work home, we work closely with organizations of all sizes, like Black Women's Agenda, that have deep ties to community, so that not only are we delivering ads to encourage vaccinations, we're actually meeting people where they are at their community fairs, in their senior centers, at their universities, and even inside their nursing homes. Our campaign goals are pretty straightforward. We want to increase vaccinations. We want to increase trust, public trust in vaccinations, and we want to make sure that everyone knows how to access these vaccines. So last year, infections from COVID, flu, and RSV hospitalized more than 1.5 million people in the United States. And 90% of those adults who were hospitalized for COVID were not up to date on their COVID vaccines. For the flu, people who skipped their annual shot were actually twice as likely to need medical help for the flu. So we have a lot to contend with, and we're making sure that we're reaching people who need to hear our campaign's messages the most, because they're at an increased risk, and they are adults 65 and older, including those in residence homes, healthcare navigators, which is just a term to describe the people, often family, who help a patient navigate the healthcare system. Secondarily, and importantly, we're delivering ads that are tailored to doctors, pharmacists, and other healthcare providers, so that we're helping them facilitate those conversations with their patients around vaccine administration. But, a lot of us know this very real fact. A lot of us are working in that space. A lot of us here are actual physicians and clinicians. For many of our audiences, the impacts of these viruses are much greater. So adults 65 and older and those living in nursing homes have the highest risk of serious illness from COVID, flu, and RSV if they're not vaccinated against these viruses. And last year, Black adults were nearly twice as likely as Hispanic and white adults to be hospitalized for flu, and were about 25% more likely to be hospitalized for COVID as Hispanic and white adults. So that is an issue, right? Contending with these health inequities in already a very challenging time. So the Risk Less, Do More campaign, for that reason, includes really tailored messaging, tested and tailored messaging for advertisements for older adults, for Black. We know that vaccines are our best defense, right, against getting very sick. And if you get infected with one of these respiratory viruses, they cut your risk of being hospitalized for flu or COVID by about half. And they make your symptoms milder, which helps you recover more quickly. That way you can get back to doing the things that you love, like going to class, going to church, gathering with your families for the holidays without worrying about infecting other people. And because doctors and pharmacists are the ones who often that we often look to for vaccine guidance, we're working closely with them to make sure that we're equipping them with real tangible resources and messages and data to help them have those conversations with their patients. Before my closing, I want to stress that what we're doing is working, right? We're looking at the data. Since we launched in August, we've developed and delivered over 800 ads on social and digital media, garnering hundreds of millions of impressions. We've secured partnerships with over 50 national, state, and local organizations. We've developed dozens and dozens of campaign resources for folks like you, for organizations, and for other healthcare partners. And close to 800 articles have been published about the campaign. I say that not to, give myself any adulation or my team, but because it shows that the investment that we're making is reaching the people that we intend for these messages to reach. And so that is a really good thing. What I want to leave you with now is just a few call to action so you can get to the meat of what will be, I know, a great conversation. There should be a slide that's teed up. But first and foremost, I'm going to say something that I said at the Black Women's Agenda Symposium, I forgot the word for a second, town hall that recently took place here in DC. Black Women's Agenda has been showing up for Black women and Black communities for decades, right? We know that, but we have to show up for ourselves. Showing up for our community starts with our own health. So that first call to action is, if you have yet to do so, please get yourself vaccinated for COVID, flu, and RSV if you're eligible, so that you can risk less and do more of the things that you love. And the best way to find a vaccine near you is to visit vaccines.gov. Second, share this same message. Repeat what I just said to everyone around you and everyone you love, especially those who are older or who have underlying conditions because they're at a great risk. And finally, as indicated on the slide, there are a couple of links, sites that you could visit to access some of these resources that we develop. So you can go to Risk Less, more about the campaign and the work that we're doing. If you're interested in partnering with us, if you represent an organization, feel free to reach out. And if you'd like to get hands on the resources that I've mentioned that we've created for the general public, for partners, for doctors, things like social media graphics, post copy, posters, fact sheets, things that you could actually display in your office or in your home and share out. There's a e-file sharing site we set up. The URL and the login details are on the slide shown here, but I can also try to plug them into a chat if one is available. So absolutely important that we carry these messages through. Thank you again for holding space for me to talk a little bit about our work. And thank you so much for your time.
May, thank you so much for joining us. I don't know about our panel, our guests, but I know I was taking notes. And one of the things that I heard you say, and I heard you say loud and clear, this is working. And so if we know that it's working, if it's data driven and showing us that it's working, we want to make sure that we are continuing to risk less and do more so that we're taking control of our own health and protecting those we love. So thank you so very much for joining us. We will drop that information in the chat. You can go to the BWA website and it will be there. And of course, you can always go to vaccine.gov and get all of the information that May just spoke about, because we want to make sure that everyone stays healthy and we want to make sure that you risk less and do more. So May, thank you for joining us tonight. We're very excited that we had that excellent presentation, and it really does lay the groundwork for our next panel. We are going to now move into that next panel, which will be a presentation and a conversation with our esteemed physician panelists. Our next two panelists are both amazing experts on tonight's topic, and it is my pleasure to introduce each of them. First, Dr. Virginia D. Banks, known to friends as Dee, is a native of Raleigh, North Carolina. She is board certified in internal medicine and infectious diseases. She is a fellow in the Infectious Disease Society of America and an active member of the National Medical Association. Dr. Banks is presently with Northeast Ohio Infectious Disease Associates in Youngstown, Ohio. She recently completed 15 years as the head of infectious disease at the University of Pittsburgh Medical Center Horizon campus in Hermitage, Pennsylvania. Dr. Banks is also the new chair of the George Counts Interest Group of the Infectious Disease Society of America. So join me in welcoming Dr. D. Banks. Our next panelist is Dr. Virginia A. Caine, and she is the Director and Chief Medical Officer of the Marion County Public Health Department. She is an Associate Professor of Medicine at Indiana University School of Medicine Infectious Disease Division. She is a past president for the American Public Health Association, and she was recently installed as the 125th president of the National Medical Association. She serves as the chair of the NMA Infectious Diseases section, and she's a member of the NMA COVID-19 Task Force. She is a past member of both the Indiana COVID Vaccine Allocation and Distribution Work Group and the ACIP Pneumococci Vaccine Working Group. I'm sure I mispronounced that, but I know that Dr. Caine will correct that for me. She is also a member of the CDC Morbidity and Mortality Weekly Report Educational Board and CDC Board of Scientific Counselors Deputy Director for the Infectious Disease Federal Committee. And both of them served on the past administration of the Links Incorporated's COVID-19 Task Force, I'm very proud to say. Their mission is to advocate for the elimination of disparities in healthcare in general and infectious disease in particular. So tonight, Dr. Caine is going to present on the flu and RSV, and Dr. Banks will then present on COVID-19. After their presentations, we will have a conversation about these very serious pan-respiratory viruses. Dr. Caine and Dr. Banks, thank you so much for joining us this evening, and welcome to our virtual stage. Dr. Caine.
Yeah, thank you. I'm just so honored to be a part of this Black Women's Agenda and this fireside chat with you, Kimberly. We've just had so many incredible collaborations between the National Link Incorporated as well as with the Black Women's Agenda. So we're just honored to be here. So I'm going to start and talk about the influenza. You know, we had the influenza pandemic back in 1918. And this is one of the worst in the history. Greater than 50 million people died worldwide for a 4-month flu, and we had 675,000 people die here in the United States. We had more people die than World War I, World War II, the Korean War, and the Vietnam War. So you can see how serious influenza can be. Next slide. When we look at influenza, we realize that there can be as many as 50-some thousand cases of deaths as a result of influenza. as many as 710 hospitalizations, but my goodness, 9 to 41 million individuals are inflicted by contracting influenza in our world. Next slide. So the flu, though, hit our Black Americans particularly hard in 2022. For the first time since 2010, we saw more hospitalizations from Blacks at 4 times the rate of our white counterparts. And if you were a Native American, you were having almost a 30% higher rate of hospitalizations than our white counterparts. Next. But the disheartening thing was that when we looked at our children and our young teenagers, we found that 2 out of 4 teenagers who were hospitalized had never been vaccinated. Next. So all in all, the influenza morbidity and mortality is attacking everyone. And the group that is attacking the greatest are children between the ages of 5 and 11 years of age, followed then by children under 4 years of age, and then our next group of children between 12 to 17 years of age. And so we're seeing 3 to 4 times of our children being hospitalized for influenza compared to white children. And our Latino children are very similar to our African American children rates for hospitalizations. But the Native American children even have 4 times the rates of hospitalization compared to white children. Next. So all in all, it is so critical that we're recommending influenza that we have to be concerned about pregnant mothers, because our babies don't have protection in the first 6 months of life. They're dependent upon their mother's maternal antibodies. So it's so critical for pregnant mothers to be vaccinated because their symptoms can be worse. And so if you have that abrupt onset of a fever, you have a fever up to 104 degrees, and you can have sore throat, malaise, even a headache, and nasal congestion related to symptoms of pregnancy, which may be more severe if you're pregnant compared to if you were non-pregnant. Next. And also realize that we're seeing almost 3 times the death rates of Black pregnant mothers who experience influenza compared to their white counterparts. Next. But the most critical thing is that we realize that these pregnant mothers will have a more severe clinical course. They'll be more likely to be hospitalized and admitted to an intensive care unit. And they're at a higher risk for dying because a number of our pregnant women, a significant number, may have comorbidity. They may have a high blood pressure. They may have pulmonary disease like asthma or diabetes, or maybe overweight, or they may be, more important, immunocompromised. And so they can even experience greater complications if they get influenza. Next. So in most critical part of this aspect is we have now been able to document that influenza during a pregnancy, especially in a mother in the first trimester, can lead to fetal congenital abnormalities just from the pregnant mother having an influenza infection. And we also recognize that hypothermia, if pregnant mothers can have a really high fevers, that also increases their risk for congenital abnormalities. And so that can be reduced if pregnant mothers are treated with antipyretics to help lower their fever. Next. So I want to say that as soon as someone suspects that they may have influenza, and that they are a high-risk patient, outpatient, where they can go on to develop pneumonia, we really need to start on antiviral medications that we have available for them. And it needs to be started within 48 hours. You do not wait for a laboratory confirmation. It's critical to start that medication earlier, and which will prevent and reduce your chances of hospitalization. And there's some of these antiviral options are more appropriate if you're an adolescent or a young adult versus if you're pregnant. Next. So, hey, and now the prevention, that's a vaccine is critical. Next. And so the effectiveness of these vaccines have been documented repeatedly, showing that these vaccines prevent flu-related hospitalizations. It prevents organ failures that can occur among influenza patients, and the one that's most critical is death related to influenza. So CDC recommends everyone 6 months and older get an annual flu vaccine. Next. So this is key. If anyone, let me just say that if you're in your golden years, and if you don't know what that is, that's meaning that you're 65 years and older, okay? And so you have at a higher risk of developing complications, because as you mature, your immune status sort of weakens, and it's not as strong as when you were a little bit younger and a little bit more robust and healthier. So we recommend that you get the high vaccines that have a much higher dose of the vaccines, a quadrivalent inactivated flu vaccine. And there are 3 that meet this criteria, that are quadrivalent, recombinant flu vaccines, and the fluid quadrivalent adjuvanted inactivated flu vaccine. And these are preferable. You do not want the standard flu vaccine if you're over the age of 65. Next. So I'll end by saying that we realized in the 2021 season, based on the vaccine coverage, 54% of whites had a flu vaccine compared to only 42% of blacks. So we were 12% less likely to get a vaccine compared to our white counterparts. And if you were Latino, that was even lower at 38%. But our Alaska Native Americans had a 41% influenza vaccine. Thank you. Next. So I'm going to move on and talk about this latest new virus that's taking people by storm, and this respiratory syncytial virus, RSV, which commonly used to primarily be seen in mostly young children. And they usually occur during the fall, winter, and spring. But although this is more of a childhood disease, quite recently, like in the last 2 years, we've been seeing a smattering of transmission to adults. And so it typically causes a mild cold-like symptom in adults. Next slide. But we now know that it can lead to more serious conditions and death in our older adults, particularly anyone who may have a weakened immune system. We're seeing about 160,000 adults who are hospitalized because of this RSV. And we see 10,000 deaths annually. And lastly, though, for our children under age 5, as many as 80,000 of them are being hospitalized every year. And of course, we have a disproportionate rate of Black children compared to our white counterparts. Next. So we have 3 vaccines for RSV, and CDC recommends that anyone over the age of 75 should receive a vaccine. But if you may be high risk, if you're between the ages of 60 and 74 years of age, you should receive the vaccine. And also, let's just say You can go at any time to get a vaccine, but preferably we like it if you're getting the vaccine late summer, fall, and even winter, because the peak of RSV is in January next. So I'll end by saying those who are high risk. So if you have any heart or lung disease, or if you're moderately or severely immunocompromised, maybe you have cancer, you're a transplant person, or maybe you have a liver or kidney failure, or you may have a neurologic disorder, or even those individuals who live in long-term care, you're at higher risk for contracting an RSV infection next. So I just want to say that one of the things that's really critical, don't forget, mother, if you're pregnant, that it's important that you get this vaccine to protect your newborn baby. And we recommend that you get the vaccine between week 32 and week 36 of your pregnancy. And this vaccine is very effective. It has an efficacy between 83 to 89% next. So I'll just end to say, hey, look at this pregnant mother receiving her vaccine next, and realize that newborns and children can contract RSV. And my last slide next, even young children can develop respiratory diseases and bronchiolitis in infants and young children. So I'll stop and turn it over to my colleague, Dr. Banks. Thank you.
Thank you. Thank you, Dr. Caine. And thank you, Dr. Kim Jeffries-Leonard, for inviting me. We too have shared a lot of collaborations over the years, and I want to thank you for that. I'm going to kind of go swiftly through these slides on COVID-19, talking about a few hot topics, and then go into the vaccines and trying to leave as much time as possible for questions. Next slide, please. I have no financial disclosures. Next slide. Next slide. So, May 2023, we stopped having those metrics that we used to rely on when the health department every day would tell us the prevalence of COVID-19 in our communities, in our counties, in our cities, our states, and in the United States. We no longer have that. We really only have two metrics now that we look at, that we have to really measure how we are doing with COVID-19 in the United States. One is wastewater surveillance, and the other one is hospitalizations. Next slide. Next slide. So the two slides that I just went up a little bit ago showed actually how wastewater samples were done. People wash their hands in sinks, and you have waste in toilets, and it goes into the sewer system. So wastewater monitoring is an early detection tool that can help communicate and prepare for and take action to address increasing cases of infectious diseases. People with certain infections such as COVID can shed pieces of this virus or bacteria when they use the bathroom, shower, and then it goes into the sewer system. These pieces of virus or bacteria travel from the toilet, sinks, and the shower into our sewage system. And there, before wastewater is treated, wastewater operators then take samples and send them to the laboratory. Next slide. The laboratory tests that the wastewater samples, the laboratories test the wastewater samples to detect and report on the different types of infections that are circulating, and the information is available in as little as 5 to 7 days. Public health officials use wastewater data to better understand disease trends to communities and make decisions such as providing guidance, preventing infections, to increase testing, or to increase vaccination opportunities. Next slide. So this slide is as up to date as I could get it, November the 2nd. And just sort of looking at it, the dark areas are the areas as of November the 2nd where we see increased wastewater surveillance. And so if my geography is good, Arizona, you can see Oregon, Arkansas, even Ohio, where I am, Kentucky, and Virginia. There are some states where there really isn't much data, and that's North Dakota. And the cross-hatched areas, there's limited data. So not everybody is on the same page, but this is one of the two metrics that we have. Next slide. Next slide. You know, when I hear people say, well, you know, I kind of don't want to get vaccinated because COVID really isn't the disease that it used to be, and I'm probably not going to get that sick. I really want to emphasize very strongly that long COVID is a problem, and it has been a problem and may still be a problem. We don't know everything that we need to know about long COVID. It's known as post-COVID condition. It's an infection-associated chronic condition that occurs in those individuals that have been infected with SARS-CoV-2. The virus causes COVID-19 and is present for at least 3 months, and in some individuals, it can affect them much longer. Patients appear to recover from the COVID-19 infection rather quickly, but then there are those, as I mentioned, that can go on for weeks and months. Next slide. So what are the major symptoms? And I want to say, even before I read this slide, the major symptoms are fatigue and brain fog. I myself am just recently, although doctors aren't supposed to use themselves anecdotally, just had COVID in September. And I would say for me, the biggest, this is my second infection, is fatigue, that enormous fatigue. So what are some of the other symptoms? Bloating, memory changes, problems with smell and taste, shortness of breath, and sleep disturbances. Next slide. So Black and Hispanic Americans are more likely than white Americans to have symptoms of long COVID. And some people who have had COVID early in the epidemic may have long COVID, but not be diagnosed as such because of coding changes. And if you look at those diagnoses that I gave you previously, they can be coded for many other diseases. New evidence suggests that there may be important differences in how long COVID manifests in different racial and ethnic groups. Further research is needed to understand better the mechanics for these differences in symptoms and access to care, and also if diagnostic codes assigned by clinicians may play a role. And that may be part of the problem in diagnoses too, because a lot of these long COVIDs may be diagnosed, as you can see, as something else. Next slide. Next slide. So let's get into vaccines. Racial and ethnic disparities. We've been looking at racial and ethnic disparities with COVID-19 ever since it came out, when we identified that there was a sector of the population that was disproportionately affected by COVID-19, and rolling around, we find that there are disparities in COVID-19 vaccine uptake. I'm going to elaborate on this particular slide, which shows our Asian American citizens have the most uptake of the COVID-19 virus. Next slide. So is there any way you could blow that one up? Can I have that as a poster, as a... Can you enlarge that one for me? It's important to get these numbers. Well, I'll just, because we can't enlarge it, I'll just, Black individuals, and so what this slide talks about is those ethnic groups who had, the percentage of those who had one vaccine versus those who were fully vaccinated. So Black individuals who had, let's see, 50% of one vaccine and 44% of fully vaccinated. If you look at Hispanic, 65% one vaccine, and sorry, I can't read that, 45% Hopefully you can see that a little better than me. But if you look at it, Asian Americans were first, followed by our Black population, Hispanic, Asian Pacific Islanders. And these are important as we talk about public health measures in terms of, because we still are seeing a lot of COVID vaccine fatigue. And so when you look at these racial and ethnic disparities in terms of uptake, it gives us more public health information to try to get some of these groups to increase their numbers. And this data is as of May 2024. Next slide. The good news is, if it's COVID, take Paxlovid. Paxlovid is still recommended for high-risk individuals with COVID-19. It still works against variants up to the JN1. And based on sequencing of the flirt vaccines that maybe we'll talk about a little bit in the question and answers, they should still be susceptible to Paxlovid. And we had issues with the flirt variants this past summer. Next slide. Next slide. This slide is important because it just pretty much tells you who should be vaccinated. First, immunocompetent individuals age 5 to 64, and this age group should receive one, it should be 2025 formula COVID-19 vaccine, and this includes individuals who have already received previous vaccine doses. Second, immunocompetent individuals age 16 or older, and this age group should receive 2 of the 2025 formula COVID-19 vaccine doses, with the second dose given a minimum of 2 months after the first dose. Individuals age 6 months and older with immunocompromising conditions should receive at least 3 messenger RNA doses or at least 2 Novavax vaccine doses, at least one of which is the 2024-2025 formula COVID-19 vaccine. One last point that I want to make is in terms of terminology. The CDC has emphasized that, we call these booster vaccines. They're really not booster vaccines. These are updated COVID vaccines. Boosters are vaccines that you get that still pretty much contain most of the ingredients of a previous vaccines. These include new components. And so these are updated 2024-2025 COVID vaccines for you to get. Thank you. I'm going to toss the baton back to Dr. Kim Jeffries Leonard for our fireside chat.
Thank you so much, Drs. Caine and Dr. Banks. That was very, very enlightening. A lot of data that you provided to us. And so now let's get this conversation started and get a little bit of information, a little bit of the questions that we're asking based on the information that you just provided. So how safe are these vaccines? That's probably the question on everybody's mind. We hear that all the time. Are these vaccines safe? How safe are these vaccines? Can you all elaborate?
So actually, I'll just say these vaccines are very safe. They're very effective. We've been testing these viruses. We've given over hundreds of millions of doses related to these vaccines, especially for the influenza vaccines, with the newest vaccine, COVID-19, the most recent that we just got this recent fall. But I will say that there have been some side effects related to the newest RSV vaccine, where there's some condition called Guillain-Barré. It's sort of like a weakness or paralysis related to that. But only 1 out of 10 million individuals have experienced this. So based on the benefits that you get, because we've seen so many deaths related to COVID-19, for example, we've had nearly 1 million deaths related to COVID-19 just in the United States alone. And we also have noted in the COVID-19 vaccine, especially for teenagers and young adults, there have been a few cases of myocarditis and pericarditis. This is inflammation of the lining of the heart, as well as the heart. but even those very few cases, we have seen so many deaths related to COVID-19 or chronic complications related to your heart, for example, chronic palpitations, chronic cardiac arrhythmias that will be persisting, that the vaccine actually prevents this versus the actual COVID-19 virus attacking all the different organs of your body.
Okay.
And I'd like to dovetail onto that a little bit because it's an important conversation that, especially with you're talking about adolescent boys who may be going into sports, and parents are worried. I mean, this happens in girls too, but certainly more prevalent in young men. I think there's a term that we use today, terms shared decision making, and I think you need to be clear whether or not there's a causal, you can see some causal relationship between getting the vaccine and having myocarditis and pericarditis, because we know there are other viruses that can cause that. So you need to talk to your physician, your cardiologist, to make a clear decision, because some of those diseases, other viruses other than COVID vaccine that cause myocarditis and pericarditis, once they have resolved, you can get the COVID-19 vaccine again.
Okay. So basically what you are telling us is there are some risks associated with vaccine, but these risks are no different from some of the other risks of some of the other kinds of vaccines that we take all the time that we have to take. The other thing that I'm hearing you say is that we need to be even more knowledgeable based on how old we are, based on our level of activity, so that we know the right questions to ask based on our demographic. So if we are parents of, or guardians or caretakers of young children, especially young boys, we need to make sure that we're asking certain questions. If they're going to play sports, if we're caretakers of older relatives or older people, we need to make sure that we're asking questions around that. But what you're saying is the risk, when you outweigh the devastating effect of these viruses, take the vaccine.
Absolutely.
Okay. All right. So we understand now that they're minimal risk. We need to ask the right questions. We need to weigh some things, but we need to make sure, we need to really look at the analysis of, what we might be putting ourselves at risk for if we don't get the vaccine versus if we do. Now the question is, are they covered by insurance?
Well, I think there are two things. I think that, if you're in the upper income bracket, you're employed, and depending on what type of job, a lot of times most insurance carriers are required to cover the vaccines that are recommended by the CDC. But unfortunately, we still have a significant number of our population that may be unemployed, and so they don't have access to a group discounted medication. And so we're going to ask them to really, I think Malik, Miss Malik talked about it.
Malik, Ms. Malik.
That you can go and there's a vaccine.gov where you can maybe find where you can get some vaccine at low cost or free, and then contact your local or state health department, because a lot of times they offer these vaccines too at just a very low cost or administrative cost. And if you don't have the money, we'll say, hey, if you hit the lottery, think about us then and give us some money back. But otherwise, we want you to be healthy.
I want to make sure we put that slide up again that Ms. Malik had talked about, because there is a wealth of information at vaccine.gov, even pointing you to the right places where you can get this vaccine at low or no cost, the vaccines at low or no cost. And thank you so much, Dr. Caine, for mentioning that we have resources in our backyards, our local and our state health departments that can provide this information. Before we go to the next question, I want to remind our audience that you can put any of the questions that you have in the chat. We'll be taking these questions that you have. I know that you have some. And so please feel free to put those in the chat. And as you're listening, go to, or in the Q&A, let me make sure I'm saying the right thing. Put your questions in the Q&A, and then maybe write down vaccine.gov so you can go there after this town hall is over. So We've talked about coverage. We've talked about the safety. Can you elaborate a little bit on the new home tests for COVID and influenza and when it is appropriate to use those? So we all know that they're home tests, but I think there's some new and exciting tests out. If you can, it's exciting to us. It may not be exciting to everybody else, but there's some new tests out that we can use at home. Can you talk about that a little bit?
Well, there's a test out now for testing for influenza and COVID. I wanted, before I gave the talk today, I wanted to just kind of go, they're a little pricey. It's a little pricey, just so everybody knows. It's about $24, I believe, is what the cost was of the one that I bought today. But I think where it is appropriate is for those individuals where we wanted to know whether we were infected with COVID, because many times the symptoms of influenza, although they may be quite different, may be the same. And it may be important for you from a standpoint of infectivity, to know whether or not you're infected with COVID-19 or influenza. We'll talk a little bit if you want to go into the difference in symptoms and signs, but I think those are the appropriate times that we want to determine whether we are infected with influenza and COVID. And especially, I think, from a public health standpoint, because as I said in the beginning, we have very few metrics now to measure the prevalence of COVID-19 in our community. And so this, although we don't report these, it's still a way for us to still sort of have an idea of what is going on in our community.
So I think that it is an interesting and exciting advancement that you can now do a COVID and influenza test at the you can get these home tests, and I know you mentioned they can be a little bit pricey, but is there anywhere else you can go get tested or get to use these tests? Because it is important to know if we are infected by any of these respiratory viruses, especially if we're in homes with babies, if we're in homes with older adults, if we're in homes with pregnant women. We want to know so we know how to protect ourselves and to protect them. Can we go somewhere else and get these vaccines?
So
these tests.
So you can actually kind of reach out to local health departments. A lot of times we collaborate with different local organizations, whether it's faith-based, civic organizations, grassroots organizations, neighborhood organizations, and we try to distribute those free kits for the public to utilize.
The same in our community too. We're doing a lot in collaborations with other organizations to provide those tests for individuals in the community.
Okay, so we can go back to those same resources to be able to get tested. Can these vaccines be co-administered? Can we take them at the same time? Can we go in somewhere and get all three or two of them, or how does that work?
Well, now technically they say you can take all three at the same time. I wouldn't recommend it, but I think you can take two vaccines at the same time, and we have the most knowledge and experience giving the flu and the COVID-19 vaccine together.
Yeah.
And so a lot of times you may get some soreness of the arm, you may be a little painful discomfort and whatever, but usually it resolves within 24 hours.
Well, I'm not going to kid you on not this booster, but the last one, when I took my 92-year-old mother, she did get all three at the same time. So.
Well, your mother's a warrior, so we understand. We understand how she probably did really well with those. I would say a dovetail again with Dr. Caine in saying that we have the most information regarding COVID-19 and influenza, and I would too recommend holding off a little bit on getting the RSV at the same time.
Okay, and May put in our chat. Thank you so much. Oh, this is very important. Let me make sure I stop and say this. May said that COVID tests can be ordered through the United States Postal Service, a free program by the U.S. government. Thank you so much. May, do you want to come on virtually and chat about that for 1 second?
Yeah, just a little bit more information, just because I am so close to the government side of things. U.S. households are eligible to order up to 4 free COVID tests through covidtests.gov. Let me just get the correct website, covidtest.gov. So you can go on there, put in your address, and you'll get them shipped really quickly. The other piece, if I may, I know this was discussed, but just to help clarify around the sort of Medicare, Medicaid, private insurance piece for vaccinations, if you're covered by Medicaid or if you qualify for it, you get them at no cost. So people with Medicare Parts B and D or Medicare Advantage can also get the vaccines for free. If you have private insurance through your job or like your state's marketplace, most plans fully cover the flu, COVID, and RSV vaccines through in-network doctors. But if you're uninsured, if you don't have coverage, as mentioned, right, your state and local health department can offer that at no cost, but the companies that make the vaccines themselves also offer them for free or at a lower cost. They typically have patient assistance programs. So go to their websites and find the information there. But if you want to explore like insurance options or health plans that could cover these, healthcare.gov is a place that I would encourage you to visit.
Now, I will say for some of the industry, because of the patient assistant program, sometimes there are forms and it may take up to sometimes 2 hours to fill it out. So you may need some assistance depending on who's filling out that form to get the patient assistance medications from industry.
Dr. Jeffries Leonard, I want to go back to the question that we were talking about, giving the vaccines at the same time. Mm-hmm. I do want to comment because in pediatrics, if there are pediatric colleagues out there, there was a movement when there was a time when you would come in and get one vaccine and the kid would come in and get another vaccine. But they found that there was poor adherence to parents bringing kids back to get vaccinations. And it really was not based on any real scientific information that they couldn't get it at the same time. And so what they were finding out was that if you didn't give them all the vaccines at the same time, you might lose that child and the child might not come back. Well, it's the same really with adults. And what we're saying here tonight, like your mother got all three, there are not really any evidence-based, double-blind, randomized studies to say that you can't get all three at the same time. You can. These are our recommendations, and actually some recommendations that I have read. But I myself know that I didn't get my pneumococcal when I went to the drugstore, and I really kind of didn't go back to get it till later. So if you missed opportunities, I think is the word. If you don't get the vaccinations, maybe because you know, a lot of people have to take a bus to the drugstore. We have to think about all these social determinants of health. Somebody might have to take a bus ride all the way to the other side of the city to the drugstore to get a vaccine. You don't want that individual to have to come back numerous times to get vaccinated. I think this is an important public health issue and comment that needs to be made.
I hear exactly what you're saying, Dr. Banks. I think that one of the things that we want to make sure is that we have access and easier access. And if you're there and you have opportunity, you know, it's take them all. I think I got them all at the same time also. And probably mainly because as you said, I don't know when I'm back. And I don't want to miss the opportunity. And so I think that it's very good to hear that from a recommendation and making sure that everyone is protected standpoint, that sometimes we just go ahead and get them all because there's no data that shows that there's any adverse effects to not getting them. And as I said, that maybe the discomfort that we feel in getting them certainly outweighs the risk in not getting them certainly outweighs what the discomfort that we might feel if we have three vaccines. So, you know, I think that this conversation really is just around the fact that we want everyone to be safe. It goes back to the slogan of this campaign. We want you to risk less because we want you to be able to do more. So let me ask you.
Yeah, I was going to bring up this other point that I think is really critical. It's all about the message. And, you know, we're having all that misinformation and people not always the truth. That I think that, you know, based on the age and sometimes the gender of the person, you may have to have a specific message. I had my greatest challenges, not with my seniors or anyone over the age of 50 or 55, but with the young African male in their low 20s or teenagers to get the vaccine. And what would the response be? Oh, hey, I'm healthy. I work out all the time. I never get sick. And so I don't need this vaccine. But the problem about COVID-19 is that almost greater than a third, 30% of people have COVID-19 and they have no symptoms.
Right. That's
So
right.
you can't go by like the flu.
That's right.
When people have the flu, they got symptoms. But for COVID-19, it's a totally different virus. So people can be carrying this virus, very contagious, can infect someone in your household who may be immunocompromised. You may have a grandmother whose immune system is down that you can impact. So even though you're feeling great and healthy, you can impact immediate close members.
Yeah.
But the biggest thing too, for the young adults, long COVID.
Yeah.
You can develop long COVID and you can have chronic symptoms for the rest of your life, whether it's chronic fatigue. You're so tired, you only have like 2 or 3 good hours in a day for energy. You're
Yeah.
just exhausted. And
I
then the
think
brain fog, oh my goodness. But it impacts every different organ of the body. You can have chronic joint pain forever, arthralgias, and so many things. And you can get that as a young adult with no symptoms, long COVID. So critical, so important to get vaccinated despite all of that.
I think that's a powerful message to leave right there around that. So you talked about the fact that you could get COVID. You may not have any symptoms. Let's say that's why the testing is so important, because we want to be able to know if we have it, so we know how to protect ourselves and we know how to protect our loved ones. And let me just make sure that I say this, because I think this is really important. When we talk about misinformation, Dr. Caine, I hear a lot of people say, well, I got vaccinated and I still got COVID. The vaccine is not to keep you from getting COVID. The vaccine is there to make sure that your symptoms are not severe enough that you're hospitalized or that you end up dying.
Or
So
even
when
going
we start,
into an intensive care unit. So you're on a respirator.
exactly.
And man, it can, once you are able to survive that, it may take you weeks or months just to even be able to walk or be able to breathe. And so you want to have a milder version so it's not life-threatening. Like you said, it helps prevent hospitalizations. It helps prevent you going into an intensive care unit. But more important is you can survive and not die.
And what
And
we're
I
seeing
think
in the trenches every day, too, is the same. I had a 100-year-old lady who was hospitalized because she was having a little bit of shortness of breath, but she walked out of the hospital today. She was only in for 4 days. You know, during the days of the early pandemic, this was just almost unheard of. So it is not the same disease that we saw starting in early 2020. It's a completely different disease, and vaccines have made that difference.
that is correct. So let's say we do get COVID. If you've recently had COVID, is there a need to get a vaccine?
Yes. The recommendation is you still need to get vaccinated, but the recommendation is to wait about 90 days after your symptoms have resolved. So about 90 days is when the CDC recommends that you should and can get vaccinated with COVID-19 vaccine.
Is
One
it
thing
safe
you know
to get?
about the vaccine too is that it has greater protection vaccinated versus just a regular COVID infection. You develop a little natural immunity for about 3 months, but the protection doesn't last as long. So the COVID vaccine provides greater protection and a longer period of protection up to a year, so you don't have to get the vaccine, but on an annual basis.
So I think we may have a few questions from our audience. Let me see if I can see those questions so that we can answer them, because we want to make sure that we're answering the Q&A from our audience. But I don't see the Q&A.
While you're looking for those, Dr. Jeffries Leonard, I might just also answer the question. If you're pregnant and breastfeeding, thinking about getting pregnant, you can get the COVID vaccine, and you are encouraged to get it.
Okay, let's say that again, because that's another piece of that misinformation that
Yeah, if you are pregnant, if you are breastfeeding, if you are thinking about getting pregnant, and it does not affect fertility. I think that was one of the early messages, misinformation that was out there, that the COVID-19 affected fertility in men and women. That is not true. And you are encouraged to get vaccine, because there is some evidence to show that pregnant women who get infected with SARS-CoV-2 may do worse.
Mm-hmm. That's very good to know. Before we start with the questions from our audience, I have one basic question to ask. Please tell us the difference between a cold, COVID-19, and influenza.
Well, let me just start to, one of my other pet peeves is a lot of people, you'll see them coughing, they're sneezing and whatever. And you say, wow, man, I wonder, do they have the COVID-19? And they'll say, no, I just got allergies. I just have allergies. I don't have to worry about this. And so allergies can look very similar to the cold. But usually if you have a COVID-19, or even the flu, you have a fever. A cold, you can have a low-grade fever, and usually with COVID-19 or the flu, you can have a much higher fever, up to 104. But allergies, people who have allergies, they never have a fever. So someone's got an allergy, and you think, oh, it's just an allergy, but you have a fever, that's not an allergy. And secondly, most allergy folks do not have sore throat with their symptoms. A cold, you can have sore throat. The flu, sore throat, and even COVID-19 sore throat. And the major symptom with the flu, with COVID-19 is a lot of people lose their loss of smell.
Mm-hmm.
And the flu is even more associated with major muscle aches. You feel like some elephant or somebody is sitting on your chest. Your muscles are just killing you with the flu. And the symptoms are very abrupt. It just seems like it starts just abruptly, not some gradual increasing of your symptoms when you basically have a cold. So,
I think
I don't
too,
know, do you want
Dr.
to add some other things?
Yeah, I think too that the point that Dr. Caine made earlier about, and I'm seeing this again more in the population in this era of COVID-19, is that there are not really a lot of symptoms these days. A lot of people have maybe a little upper respiratory tract infection, and they take a COVID test, and to their shock, they're COVID positive. So I think, at least from what we're seeing in the hospital, with influenza, people are a lot more symptomatic these days with influenza than they are with COVID-19.
Are we moving to a herd immunity?
Well, I think, I don't like to use that word.
I didn't mean to say that.
To get there for the herd immunity. So we're trying to get there. If so many people are vaccinated with COVID-19, then that can provide enough immunity so it's not spreading to a lot of people.
I think we're close. I think we are very close. I talk about it all the time. That virus, although the thing about this virus that we really have not seen in a virus in our lifetime is the mutation, the mutations that occur with it. But this virus is hitting brick walls. It's hitting brick walls, as it should, from all those individuals that have been vaccinated. And if you will, a lot of the subvariants are cousins, if you will, of the Omicron variant. And so there's a lot of cross-reactivity with protection. So I think if we're not there, we haven't seen any major studies right now. It may come out in a few years, but we're getting pretty close to herd immunity, I think.
Okay. So let's take some questions from the audience now. We have one audience member who's 67 years old and only dealing with high blood pressure and has no respiratory issues. Praise God. They had their flu shot. Should they get the RSV vaccine?
So let me ask you this too. First of all, one, do you have any grandkids that are under the age of 5 or 10? So when you're also getting an RSV, I know my nephew told me, well, hey, our two little babies, and no way I was stepping in his house unless I got vaccinated for RSV to protect his babies. He was very serious about it. He did not let us in the house. So I said, oh my goodness, I forgot to get my RSV vaccine. And it takes 2 weeks after you get the vaccine that has a protection. So it may not necessarily, it's important for you with the hypertension. You do have a risk factor where you're at higher risk for complication for RSV. So I do think you should get a RSV vaccine, but also think about who's visiting with you in your household, or who are you going to visit? And if there are any young kids under the age of 5 and under, please get that RSV vaccine to protect your young ones.
If you get a vaccine, do you have to get it again?
So RSV is different. So what we found out is from the 3 vaccines that right now, because they're newer, they only got approved in 23, but they are having at least a 2-year protection period. So if you got an RSV vaccine last year, you don't have to get one this year. And we'll know a little bit more in the 3rd year of these vaccines, whether how long this protection will last.
So you're gonna let us know.
That pneumococcal vaccine that you had mentioned that I'm on the working group with, that's a vaccine that prevents the #1 cause of bacterial pneumonia, the #1 cause of pneumonia in this country.
Okay.
But that vaccine can last for give you 5 years of protection. We just don't know yet with the RSV vaccine, but at least 2 years.
I think too, why this chat that we're having tonight is important, is that this is November. We're getting into the holiday season. And our numbers right now in my hospital are a little lower than they have been, but we're waiting for that peak, which we have seen every year. So you're getting in, it's getting colder.
Right after Thanksgiving.
Right at Thanksgiving, people are going to start getting together for Thanksgiving dinners. Christmas is coming. So this is the right time for you to start getting your vaccinations to prepare for preventing.
So let's talk a little bit.
Travel on an airplane. So let me just tell you, that's enclosed. You have people from all different places. Nobody traveling should travel in a plane without carrying your mask for protection. In case you're sitting next to somebody who's coughing in front of you or behind you, carry that mask. And I prefer that you wear it while you're on.
Thank you, Dr. Caine. She's preaching my language now. Thank you so much. So let's talk about COVID tests again. Can we use expired test kits? How long after the expiration date are they good for?
I'm sorry, go on,
Jenny. Because some of them will tell you, some of the companies, even the government, have told you that some of the tests you've been able to use it 6 months after it's expired.
Or even
usually they will tell you that.
Yeah.
The government.
I call that when I had COVID, I called the CDC actually, because I had some expired COVID tests here, and they said even from up to a year, as you said, you can still use these tests.
And if you go on the FDA website,
I feel good at 6 months. I think you have to know if it's longer, you have to see those recommendations from like a federal agency.
So you can go on the FDA
website to know it still works,
and you can put your lot number in there.
Exactly.
Yes, tell you exactly how long.
Exactly.
That's a good point. Yes.
Exactly.
How long that test is good for. Right. Let's talk about clinical trials and Black folks in clinical trials. Do you want to expound a little bit more? We have a question about about the fact that are Black people included in clinical trials, and do they need to be?
So one of the things that I think that the National Medical Association does so well, we are the oldest Black physician organization in the country since 1895. And I have to make this point, Kimberly, for the public for us to understand. So when you see Medicaid and Medicare, that was because of the advocacy from the National Medical Association. The American Medical Association was against that. So we were there on Air Force One with President Lyndon B. Johnson signing the legislation for Medicare and Medicaid in 1965. We were in the White House, our president standing behind him when he signed that legislation. So we're very concerned about vaccines, and if we haven't had enough experience of it in Black people, there's something called precision medicine. Each of us genomically have different genes and we respond differently. We have a lot of sickle cell patients. We have a lot of HIV patients. And we have a lot of patients that may have more cofactors. So we actually drilled each vaccine manufacturer to give us the evidence that you had sufficient number of people of color in your trials for us to say we're comfortable making a recommendation of your drug. And listen, not only did we talk to the pharmaceutical folks, your Modernas, Novavax, Pfizer, we actually talked to the head of FDA as well as members of their task force to make sure everything is in line. So we don't want to get out there and recommend something without us doing our good diligence. Because, hey, it's my loved ones that are getting the vaccine. I'm giving the vaccine to myself. So we're trying to do everything we can to protect our people of color, regardless of your race, age, gender, because that's our oath. That's what we do.
I think there are more people, again, looking at HIV/AIDS who are Black and brown people who are now head of these clinical trials that are now in positions where they can make a difference, and making sure that the Black and brown people are represented, men and women. You know, we had a problem with women representation in a lot of clinical trials, not just in racial and ethnic disparities. So, you know, again, we have, especially in HIV/AIDS, a lot more Black and brown people in positions of authority to insist that this is done.
Okay.
But more important than that, we've got some incredible Black scientists and Black health professionals that are leading the charge. We had a Black female scientist, remarkable young lady, leading, helping with the development of the Moderna vaccine. That's incredible.
I think Dr. Banks interviewed.
I did a webinar with her, Kizzy.
Yes, you did.
Yes,
Dr.
it's
Kizzy.
incredible.
Yes, incredible.
So talented and 33, but she's been in health doing research since she was in high school.
Yes.
And incredible. But let me tell you this. You know and I know that if you're in an accident and you might require a blood transfusion, who do you think revolutionized blood transfusions in this country? It was a Black doctor called Dr. Charles Drew who got his experience in World War II and brought it back to the United States. A Black man, a Black physician, a doctor is responsible for blood transfusions. So you got to understand, we're doing incredible work out here. Scientists, healthcare professionals, and my goodness, think about those nurses, physical therapists who were on the front lines with this COVID-19. Remember when this epidemic started, we didn't have protective gowns enough. We didn't have enough masks. And, you know, these hospitals were overwhelmed, you know, packed in the ERs and everything. And despite that and the risks, we were on the front lines.
You know, I think we owe a lot to all of these, amazing healthcare providers that had to navigate the early days of this pandemic with this. And I thank the researchers who have gotten us to this point and the people who have advocated for us to be able to ensure that we have the tools that we have now, the vaccines. That's why it's so important for us to be on this call to talk about, you know, this tool, this vaccination that really is here to keep us healthy and to keep our loved ones healthy and our communities healthy. So we're going to wrap it up. 2 more questions before we go. One first question. This winter, I had 3 vaccines for the first time because I turned 60 years old. Welcome to the 60 Club. So I got RSV, flu, and COVID on the same day. My arm hurt overnight, but was fine. Do we need to set expectations for that? Do we need to let people know what they're going into so they're not
Well, I think, and here's a point that has been another question about taking antipyretics and ibuprofen and such drugs around vaccinations. And, I think most people with most of the vaccines, pneumococcal might, with any injection, you're going to probably have some site issues. And so, yes, you probably should remind people that your arm's going to be sore. The shingles vaccine, your arm is sore. Yes, but I think another point that I want to make, and again, in just doing a little bit more research, because it's a question that a lot of people have asked me. If you know you're going to have a vaccination, should you take ibuprofen or Tylenol or some antipyretic before you have your vaccination? That is not recommended. It is recommended that you take these after you are vaccinated. Again, they're not big randomized double-blind studies to show that there's a decrease in immunity, but it's just you're taking an anti-inflammatory drug and an antipyretic that may affect your immunogenicity, and you don't want anything to interfere with that. So yes, tell your patients that your arm's going to be sore, and cold packs and all those kinds of things. So I think, but again, risk-benefit ratio.
So this last question, I call it the OG question, because you all are the OGs, and you have been in the trenches, and you have pretty much seen everything. And so this question is, we have seen other symptoms of long COVID, like inability to walk or work. Have you seen this too?
I'm sorry, repeat that again.
We have seen other symptoms of long COVID. So, you were talking about long COVID and some of the symptoms and how it would impact you. So this question is, we have seen other symptoms of long COVID, like inability to walk or work. Have you seen this too?
I have. I mean, I see patients every day with long COVID. The problem is, again, because we don't have a lot of studies, a lot of times there is difficulty in causality of whether or not the symptoms that you are seeing, particularly, let's say, somebody who can't walk or who has a lot of chronic issues, whether or not that is truly causally related to COVID, SARS-CoV-2. And that was the issue that I was talking about in terms of coding, that a lot of physicians, again, are confused. I mean, we still have a lot to learn about long COVID, but the bottom line answer to your question, yes, I have seen patients and have patients that can't get out of their wheelchair who had COVID a year ago. Very, very debilitated, but can you 100% say that it was related to their SARS-CoV-2? Well, they had a, significant infection at the time, but that causal relationship is going to be very important for that.
It's tough, but they've got an NIH study that's been going on now for a couple of years, so they're trying to get at that answer. Kim, I got to just pipe one little thing in before you close us out. And it's all about this new pneumococcal vaccine recommendations that we have lowered the age for people to get that pneumococcal vaccination at age 50 instead of 65. Because, Black males, their life expectancy is 68 years of age. So if you wait until 65 to get the pneumonia shot, the pneumococcal vaccine, you only have 3 years benefit. And we know that Black Americans, we have our pneumococcal vaccine disease almost 10 years earlier than our white counterparts. And we have the greatest invasive pneumococcal disease compared to any other racial and ethnic group. We made history with CDC making this new announcement that occurred in 30 days. So make sure you have us come back to talk about that. Thank you.
Hot off the press, get it earlier, live longer. It allows us to be able to do more. And there was a shout out in the chat to Dr. Caine about talking about clinical trials and mentioning that NMA has a program, Project Impact, that works to train our physicians so that they can get people into clinical trials. So thank you for all that you all are doing. So we will come back. We will have more conversation. I want to take this time to thank all of you, to thank Dr. Caine, Dr. Banks, Ms. Malik for coming and joining us tonight and talking about something that is very, very, very important to our communities. And that's the importance of getting vaccinated for flu, RSV, and COVID-19, because we want you to be able to risk less and be able to do more. So thank you again for coming. I want to thank our national collaborating organizations. I want to thank the National Medical Association and the Black Coalition for Health. You see here all of our partners on the screen, and we want to thank them for joining us, for being a resource, and for being so supportive in making sure that we get this information out to all of our communities, because it is truly, truly important. Don't forget, go to vaccine.gov to get all of the information you need for yourself and your loved ones and your communities, even those you don't love so much. Just make sure everybody gets this information, because it is important, it is critical, and we need it now more than ever. So thank you again for coming, whether you're watching us on Zoom, Facebook, or YouTube. We appreciate it. Stay healthy, get vaccinated, risk more, do less. Have a good night.